You've done this. I know you have. You're standing in that roped-off line at the pharmacy counter. A woman ahead of you is arguing about a prior authorization she doesn't understand. A kid behind you is sneezing into his sleeve. And when it's finally your turn, the tech scans the bag and says, "That'll be $9. $9. You tap your card. You walk out. You never think about it again. Here's what I want you to sit with. That $9 is not the price. Not even close. The money in that transaction touched 4 different companies before it reached the person who handed you the bag. And by the time it landed, that pharmacy might have made $2. Or it might have lost 11. And after 15 years of reading small business P&Ls, here's the part that still bothers me. They won't know which one for another 3 months. So let's walk through the real economics of owning a pharmacy. Not the version where you're a beloved pharmacist in a cardigan who knows everybody's grandkids. That version exists, it's beautiful, and it's going out of business at a rate of more than 1 store per day in this country. I'm giving you the version on the spreadsheet. Pharmacy covers 4 businesses with almost nothing in common financially. Community retail fills prescriptions for walk-ins and lives on volume. Long-term care services, nursing homes, no storefront, just a delivery van and a contract. Compounding mixes formulations that don't come off a manufacturer's line. Specialty handles the $6,000 a month drugs. Same license, same state board, radically different businesses. Retail is a store with a healthcare license bolted on. Long-term care is B2B logistics. Compounding is small batch manufacturing. 90% of what you picture is the first one. But hold on to the other 3, you'll soon see why the people who actually make money almost never stay in category 1. Say you're a licensed pharmacist. 6 years of school, the PharmD. 5 years at a chain watching corporate cut your tech hours every quarter. You want your own store. What's the check? $400,000 to $800,000 to get to opening day. And the biggest chunk isn't what people expect. Not the build-out. Not the software. Inventory. You need $150,000 to $300,000 of drugs on shelves before a single patient walks in. Broad enough that when somebody shows up, you actually have it, because if you say, "Come back Thursday," they don't. They go to the CVS across the street and you never see them again. Then build out on 1,500 square feet. $100,000 to $200,000 for the counter, the consultation room, ADA compliance, the security cage for controlled substances, refrigeration, $25,000 to $50,000 for the software. Then permits, DEA registration, insurance credentialing. That last one is where the first gut punch lives. Let me tell you about my friend Nate. We met in a finance elective in 2010, the only pharmacy student in a room full of finance majors, asking better questions than any of us. In 2019, he bought a struggling store outside Toledo, and he called me on a Tuesday in a panic because he'd opened his doors and discovered he couldn't bill anybody. Getting contracted with the major pharmacy benefit managers, the companies that actually pay for most prescriptions in America, took nearly 5 months. 5 months. $400,000 of capital deployed, a lease, 2 employees, a full shelf of inventory, and he was cash only. He burned his entire working capital reserve before he processed his first insurance claim. Nate survived, but he said something I've repeated in 30 conversations since. Everybody budgets for the build. Nobody budgets for the wait. Doors are open. Let's follow one script through the machine. A patient hands you a prescription for a generic blood pressure pill. 90 tablets. You bought that bottle from a wholesaler, McKesson, Cencora, Cardinal, for $9 and change. You dispense it. You submit the claim to the patient's pharmacy benefit manager. 4 seconds later, the PBM tells you 2 things: what the patient owes and what the PBM will pay you. You don't negotiate that number. You don't quote a price. The PBM tells you what your price is. Take it, or don't be in the network. Say it comes back at $12.40. Patient pays a $5 copay. The PBM pays the rest in about 2 weeks. Gross profit, roughly $3. Now think about what happened inside that $3. A professional with a doctorate reviewed the script, checked it against every other drug that patient takes, counted it, labeled it, counseled the patient, Rent, labor, software, insurance, and the pharmacist's own salary all come out of $3. Industry-wide, the numbers are consistent and brutal. Independent gross margin prescriptions and the front-end candy aisle combined has fallen under 20%, the lowest in a decade of tracking. Net margin lands around 2 to 4%. Put that next to something. A decent laundromat nets 20 to 30% and requires no professional license at all. A pharmacy with a legal monopoly on dispensing nets 3. Why? One structural fact. Write it down. In a pharmacy, you don't set your price. You don't control your cost, and the person receiving the product isn't the person paying for it. That's not retail. That's subcontracting. You cannot understand this business without pharmacy benefit managers. PBM started in the late 60s as a useful idea. Insurers didn't want to process millions of tiny drug claims, so specialized firms did it. 50 years later, 3 of them, CVS Caremark, Express Scripts, and Optum Rx, control the overwhelming majority of prescription claims in America. And each sits inside a company that also owns pharmacies. Caremark is CVS. Express Scripts is Cigna. Optum Rx is United Health. The entity setting your reimbursement rate is a division of a company that competes with you for the same patient. Imagine if Amazon set the wholesale price your bookstore paid, set the retail price you charged, decided which customers could shop with you, then audited you at year-end to claw back money it had already paid. That is genuinely the structure. And regulators have documented it. The FTC has published findings showing enormous spreads between what these middlemen charge health plans and what they pay pharmacies for the identical drug. One widely cited example, a cancer medication a pharmacy could buy for under $100, billed out at over $19,000. Rosa runs an independent in San Antonio. We met at a conference in 2022, and we've traded emails ever since. Last spring, she sent me a screenshot of her claims dashboard, no patient info, just the reimbursement column, and about a third of the lines were negative numbers. Negative. She paid more for the drug than she got paid to dispense it. I asked the obvious question. Why fill them? She said, because it's Mrs. Alvarez. She's 81, and she's been coming here since my dad ran the store. What am I supposed to say? That's the real trap of this business, and no spreadsheet captures it. Now, the mechanic that takes a bad situation and makes it dangerous. For years, PBMs assessed DIR fees, direct and indirect remuneration. In plain English, you fill a prescription in March, get paid in March, book the revenue in March, and 6 months later, the PBM reaches back and takes a chunk of it based on metrics you often didn't fully understand and couldn't control. Regulators forced a change in 2024 that pushed most of those fees to the point of sale. So at least you see the hit up front now. Real improvement. But the retroactive culture didn't disappear. It changed shape into audits, recoupments, reconciliations. My friend Ellie owns 2 stores in central Pennsylvania. In 2023, she got an audit letter over documentation, signature logs, refill too soon flags, the kind of thing that sounds like paperwork. It was $46,000 on a business netting 3%. Ellie told me the money wasn't what broke her. It was that she'd already spent it. She booked that revenue 11 months earlier, paid her techs with it, made her lease payment with it. You cannot manage cash flow when your revenue is provisional. Here's how I describe a pharmacy's balance sheet now. Your accounts receivable are not receivables, they're estimates. Want the cleanest example of how upside down this industry is? The weight loss and diabetes drugs. Ozempic, Wegovy, Zepbound, Mounjaro. The biggest pharmaceutical story of the decade. Exploding demand, refills every month, patients who'll drive across town. For most independents, a financial disaster. A 1-month supply might cost the pharmacy north of $1,000 from the wholesaler. Reimbursement often comes back at or below that. Survey work from the Community Pharmacy Trade Association has found stores losing $30 to $40 on every fill. Read that again. The hottest product in American medicine, and every unit through the door is a loss. Dev runs a store in a Chicago suburb. He walked me through it over dinner in 2024. In about a year, roughly $2 million of GLP-1 product moved through his pharmacy. $2 million of inventory financing, cold chain handling, staff time, refrigeration, net contribution to profit. Negative. He said, I have a $2 million product line that's a charity, and that creates something strange. Your revenue line explodes. A lender looking at Dev's gross sales would think he was crushing it while his margin got eaten alive. Some owners simply stopped stocking them. Sounds rational until you realize the patient who can't get her GLP-1 at your store also stops getting her blood pressure pills, her statin, and her kid's antibiotic there. Losing money on one drug is a margin problem. Losing the patient is existential. Take a mid-sized independent doing 200 prescriptions a day, 60 to 70,000 a year, right at the industry average. Call it $4.5 million in annual revenue. Sounds like a real business. Watch. Cost of goods is the monster. At a sub 20% gross margin, 80 cents of every revenue dollar goes straight back to the wholesaler. 3.6 million out the door before anything else. You're left with about 900,000 to run everything. Payroll is the biggest line. A staff pharmacist costs 125 to 150,000. And here's the part people miss: you can't legally open without one. Not should have, cannot operate. If your pharmacist has the flu and you can't find a floater, you close the store. Add 2 to 4 technicians, a driver, a front-end clerk. Payroll lands at 4 to 500,000 all in. Rent, 50 to 120,000. Software, 15 to 30. Insurance, 20 to 40. Delivery vehicle and fuel-free delivery is table stakes now, not a perk. 15 to 25. Plus utilities, security, card processing on millions in transactions, accounting, legal, and the inventory that quietly expires on the shelf. Total, 8 to 900,000 against 900,000 of gross profit. That's the whole business. That's why net margin is 3%. No fat to cut, no clever tweak that finds you 200 grand. The structure is the structure. And the structure is why more than one independent closes in this country every day. Why the total has fallen below 19,000 locations. Why Rite Aid went through 2 bankruptcies and then simply ceased to exist after 63 years. Why Walgreens announced plans to shut roughly 1,200 stores. Why 1 in 7 Americans now lives in what researchers call a pharmacy desert. That's not a business cycle. That's an industry restructuring in real time. Here's my favorite part, and almost nobody talks about it. Some pharmacy owners are doing extremely well, not scraping by genuinely well, and they share one trait: they stop depending on dispensing. Let me tell you about Sharon. Sharon bought a tired store in rural Georgia in 2016 for less than the price of a nice house. On paper, it was a bad business: declining scripts, aging population, a Walmart 9 miles away. Today, she does about $6.5 million a year, and walk-in dispensing is under half of it. Here's what she built. Long-term care. 4 nursing homes and 2 assisted living facilities. Bubble-packed meds, delivered on a route. Invoiced monthly. Not glamorous, no storefront, but contracted. Predictable volume. Compounding. She makes things that don't exist commercially. A pediatric dose of a drug that only comes as an adult tablet. A veterinary formulation. A hormone cream. There's no PBM set price for a product no manufacturer makes, so she prices it herself. Margins run 2 to 4 times retail dispensing. Clinical services, immunizations, testing, medication therapy management paid as services, not products. Durable medical equipment, braces, diabetic supplies, compression garments. Better margins. Patients already in the door. Cash pay. This one's the philosophical shift. For a growing list of generics, the cash price beats running it through insurance. She built a transparent cash program. No PBM, no clawback. No 90-day float. Patient pays, she keeps it. Done. Sharon gave me the sentence that became my whole framework for this industry. I stopped trying to win a game where somebody else keeps score. That's it. That's the entire thing. Tommy, a wholesaler rep I've known for years, who sees hundreds of these stores' buying patterns, put it differently. The healthy independence he calls on share one number dispensing is under 60% of gross profit. The ones circling the drain are at 95. Let's talk exit, because that's where a lot of the fantasy dies. Independents typically trade around 2 to 3 times sellers' discretionary earnings, or 3.5 to 5 times EBITDA. Another rule of thumb prices them per annual prescription, often $40 to $80 per script. Frank sold his store outside Sacramento in 2021, after 31 years. 3 generations of the same families. A beloved institution, his offer came in slightly below the value of his inventory and his prescription files. 31 years of goodwill priced at zero because the buyer wasn't buying goodwill. He was buying a patient list and a shelf of drugs. And both have a market price. Frank was fine. He'd pulled a good income for 3 decades and owned his building, which turned out to be the real asset. But he thought he'd built equity in a business. What he'd built was a job with inventory attached. Job versus asset. That's the most important question in every small business I've ever analyzed. The good version. You buy an existing store with 60,000 annual scripts for $2.8 million. 20% down, SBA loan for the rest. Year 1, you keep the staff, keep the patients, net, 200,000 of owner earnings, 110 of which goes to debt service plus your salary. As the pharmacist, Year 2, immunizations and a compounding lab. Year 4, a nursing home contract. By year 6, dispensing is half your gross profit. You're netting $400,000, and the business is worth double what you paid. That happens. Sharon is that. The bad version. You build from scratch for $600,000. Credentialing eats 5 months. A chain opens 2 miles away in month 8 and starts mailing your patients 90-day supply offers. Your GLP-1 patients are all loss makers. An audit hits you for $30,000 in year 2. Your pharmacist quits, and you work 70-hour weeks behind the counter. Yourself 0 hours left to build the service lines that would have saved you. Year 4, you sell the files to a competitor and close the doors. That's the one closing daily. The distance between those two isn't luck, and it isn't how good a pharmacist you are. It's whether you understood from day one what business you were actually in. So here's where I land. A retail pharmacy is not a store. It's a fulfillment subcontractor for a middleman who sets your price, doesn't disclose your margin, pays you on a delay, and reserves the right to take it back. Once you see it that way, everything clicks. The 3% margin, the closure a day, and the escape route, because if someone else controls your pricing, every dollar of revenue you build outside that system is worth several dollars inside it. The winners here aren't better dispensers. They're the ones who figured out that dispensing is the customer acquisition channel, not the business model. The prescription gets the patient through the door. Everything else is where you actually get paid. And that's true of far more than pharmacy. Dentistry, veterinary clinics, primary care. Anywhere a third party sits between you and your customer, the game is identical. Find the revenue that middleman doesn't touch. If this changed how you look at that little counter at the back of the drugstore, hit subscribe. We do one of these every week businesses everybody sees and nobody understands. And drop a comment. What business have you always wondered about? Self-storage, dialysis clinics, dental practices? I read every one, and a lot of these episodes started as somebody's comment. I'll see you in the next one.